Gary Thompson with Dixon Hughes Goodman, one of our past chairs. Their organization has a group called DHG Healthcare. They provide services to many of the well-known healthcare brands in the country, the 9th largest privately held healthcare consulting firm in the United States. They have about 300 professionals. We have a great panel here to continue our discussion on this important topic. Hope you all have enjoyed your break. I was asked about Q&A from the audience. I think my first year we did this conference, we had Q&A from the audience, and rather than concluding at 2 o'clock, I think we ended at 4 o'clock that day. So we're mindful of people's times, but we are going to ask the panelists sort of to stay up front like they did in the last panel, and for those of you who have an interest, that they can come up and talk to you here in the front directly afterwards in our break that will come up after this panel. So thank you very much for coming back and for your attention and for your focus this morning. And please join me in thanking Scott and DHG Healthcare. And we look forward to this panel. Please welcome all the panel.
Thank you, Barry. Thank you very much. Thank you. So we have the illustrious honor of being between you and lunch. So I'm not exactly sure how we negotiated this time slot, but clearly we weren't good negotiators. So our session really talks about working together. So we've heard earlier today about, hey, what are the statistics around the crisis? What are the impacts that it's having? Now we get into how do we actually put our treatments, our protocols, our approaches in action. And the apt title for this is Together. So across the panel, you're about ready to hear, we have people from all parts of the healthcare ecosystem. So as you begin to think about how we do these things, how we approach these things, you really have to approach them from a partnership perspective. How do you find true partners to try to address this crisis? So I'm going to start with introductions, and I'm going to start right here on my right-hand side with Sharon. And I'd love to hear just a little bit about yourself, sort of name, rank, serial number, all that kind of good stuff, just so everybody gets a sense of you.
Thank you, Scott. My name is Sharon Bruckner. I'm Deputy Vice President of the Pharmaceutical Research and Manufacturers Association of America, and it's a trade association based in Washington, D.C. We have about 30 biopharmaceutical companies throughout the country that are our members. A handful of them make products that are misused and abused, maybe about 4. But I'm proud to be here today talking about policies and solutions to this epidemic.
Outstanding.
Great. And I'm Dr. Maureen Dempsey. I'm the Regional Vice President and Senior Clinical Officer for Anthem Commercial. But I'll be representing both all of our lines of business here today. And we really cover our members from end to end. They're accessing the services. We're making sure that they're able to access those services using their benefits. We work with employer groups, with providers, with facilities. So we have pretty far-reaching end-to-end scope for our membership to assure that they get the care they need at the right time in the right place with the right provider.
Hello, my name is Michael Diminick. I'm an orthopedic surgeon in Lynchburg, Virginia with OrthoVirginia. In Lynchburg, I take care of Liberty University athletes, and I take care of patients all the way up through adulthood. So I take care of athletes who are trying to get back on the field by Saturday, and I take care of people like us who are trying to get back to a productive life. At OrthoVirginia, we have over 120 providers. We're the largest musculoskeletal provider in the state. So we have our hands all over this issue, because we certainly write those prescriptions that we're talking about today.
My name is Mulaney. I'm the Assistant Vice President for Behavioral Health at the Inova Health System, a large health system in Northern Virginia. I have oversight of our substance abuse programs, which range from inpatient medical detox all the way down to medication-assisted therapy and relapse prevention, and sort of everything in between. We also have a full comprehensive psychiatric behavioral health services from outpatient up to inpatient, and we have child and adolescent programs as well.
Great. I'm Jim Newton. I'm the Administrative Director of Behavioral Health for Secours, Virginia. Really happy to be here this afternoon and appreciate the opportunity to chat with everybody. I already told Scott most of the great articulate comments were already made by the other panel, so we're going to have to really work this.
We're going to have to just plus it along the way.
We're going to have to work
we'll
this.
Get there.
Again, at Bon Secours, from a behavioral health standpoint, we have 136 beds in Virginia, split between Richmond and Hampton Roads. We have a substance abuse program in Hampton Roads as well. We serve individuals from 6 to 106. We also cover our 9 hospital emergency departments with the Bon Secours mobile assessment team, seeing over 700 people a month in our EDs. We also have a 1-800 access number for individuals that are looking for psychiatric beds. So I'm happy to be here.
Jim, thank you very much. So keeping on that theme of together, we're going to sort of ask a group question to begin with, and I'll sort of direct some commentary around it, but we won't hold completely to a script. Dr. Dempsey, I'm going to actually start with you on this one. Okay. Is, as you think of your own part of the healthcare ecosystem, if you will, what do you think your part of that ecosystem, what role do you think it plays in addressing this crisis around substance abuse? So, Dr. Dempsey, I'll start with you, and then we'll continue around the group.
Great. Well, thank you for the opportunity to address this concern. I think we've heard the data, how far-reaching the consequences are of substance use, affecting families, affecting our friends, affecting the workplace. And one of the things that we've attempted to do working with the providers in the community is to establish a system of care where we can help identify members who may be at risk, misusing substances, or getting into trouble with their prescriptions, for example. We can identify providers who may be prescribing in a manner that raises questions for us, and we can reach out to that provider with our medical directors and have a conversation about what's really happening with that patient, with their panel of patients, and the manner in which they're practicing, and does it rise to a level of concern that we need to intervene in some way. We work with the treatment centers, which thankfully are expanding. You've heard about ARTS and the medication-assisted treatment centers, the office-based opioid treatment centers. We're working to establish an adequate system of care, both on the inpatient and the outpatient side, to allow our members to access care in a timely fashion. When individuals get into trouble, they may present in an emergency room. They may be ready to take an intervention at that time, and if treatment is not available, then we miss that opportunity. So part of the role that we play through case management and our behavioral health case managers and providers is to link that member at the time of their prime opportunity to the services they need and help them get them on that path of recovery.
Outstanding. Sharon, I'm going to scoot to you. So your thoughts on the role that the PhRMA plays in this particular process?
Thank you, Scott. I do believe that PhRMA has a very important role, but not a singular role. It's one of many stakeholders that's tackling a very difficult epidemic that involves multiple stakeholders. I'm a registered nurse by training, and I think that the other stakeholders I'm referencing include the provider community, includes the health plans, includes the employer community here with the terrific discussion we've had today on absenteeism, presenteeism, and the social costs that we heard, $1.4 billion in Virginia as an economic impact. And seeing 1,400 Virginians die every year from this, certainly our industry is stepping up and saying, let's come up with some policy solutions and product solutions. To answer your question, some of the product solutions we're very proud about is our trade association members make brand name medications. So we have 40 new medications in the pipeline to treat addiction. Another 40 are in the pipeline that are non-opioid alternatives, something I think all of us agree that we need more access to, more coverage, including some of our members who make abuse deterrent formulations. Certainly it's not a foolproof, abuse-proof tool, but it's one of many things that can help reduce this epidemic. So I'm proud to offer some policy solutions we'll talk about in a little bit, and of course the products that our companies make very hard, work very hard to innovate.
Dr. Diminick, I'll turn to you. Your thoughts, a role as a practicing physician, working on getting athletes, as well as those weekend athletes, back out on the field.
Well, one thing I realized several years ago was that we're on the forefront of this, and we've been unwitting accomplices to the problem, helping to create a problem. Patients come in, we hate to see them in pain, they don't want to be in pain, and over the years, the prescribing habits have changed. At the break, I heard a discussion where a child broke his wrist and went to the ER and got, 3-week supply of narcotics or something that should just be a couple days of pain. And we were sort of oblivious to this, I think, as collectively, at least as orthopedic surgeons. And you see this time and again, kids get hurt playing football or cheerleading, or they got wisdom teeth. My children, 2 of them had their wisdom teeth taken out last year and came home with 60 Percocets, which I then had to figure out how to dispose of and hid them in the closet somewhere until I could figure out what to do with them. But it's, it's a real thing that we've been really didn't pay enough attention to. It was actually Prince's death that made me take a look at what we're doing. And so I looked at our practice just in the Lynchburg office. We have 35,000 unique patients come through the door every year. When you apply the CDC's numbers to that, it would predict that we would have about 250 addicted patients in our practice. We went a step further and looked at our prescribing patterns, and without exception across the board, the 12 surgeons had 20 to 25 patients on long-term narcotics, which would put us right at that 250 number. So it met exactly with the CDC's numbers. Furthest, the CDC says that out of 250 patients, you're going to have 1 death. So within our own practice, we realized that we're definitely putting patients in harm's way, and probably patients are actually dying under our care. And so we took a step back of that and implemented more effective policies.
Gotcha. So we've heard from the PhRMA perspective, the health plan perspective, the practicing physician perspective. So Michelle and Jim, the behavioral health side of this. So Michelle, I'll start with you. Is what's that role? What do we think where does that intersect with this issue?
Sure. When we talk about addiction, we're really at a bottom of a mountain in an avalanche. So we've already arrived at this place, and how do we get back up to the mountain to stop the avalanche is the question. We really need to roll back the tape a little bit and look at individual mental health conditions. How did this particular patient, what path did they go down to get to this place? Because the path for each of them is different. When we conceptualize mental health, behavioral health diagnoses, we really focus around 4 different areas, and they are disease, a broken body part, if you will, the life story, what's going on with this person, is there grief, is there an event that happened, and what individual traits does this person have that differ from other patients, and how do we formulate a very good assessment and plan and tailorized treatment for those mental health diagnoses such as depression and anxiety. We have a flawed model in healthcare delivery, so physicians who often want to do better are given 15 minutes for appointments, and in that 15 minutes they have very little time to do a thorough assessment of what's truly going on with a patient. So you end up using things like opioids as a blunt instrument, if you will, right? So limited time, limited resources, and so what we have is we don't have tailorized treatment. So when we roll back the tape on addiction, we really need to look at what's going on with this patient in his or her life and have more sophisticated treatment options for things like pain. Pain can be very subjective. It could mean they're suffering. It could mean they're suffering emotionally. And we need to understand what that is a little bit better so we can have more streamlined treatments for each of those patients.
Gotcha. Jim?
Yeah, I think we really are on the cusp of some incredible things in the Commonwealth. The Arts SUD, the ability that we've had in the last 2 years to have twice as many providers and treatment options. To me, it comes down to access. At Bon Secours, our mission is to serve those folks that are vulnerable and difficult to serve. So for me, it becomes access. And there's really four touch points to find out if somebody has a substance abuse issue. The first one is largely jail and prison. The second one would be the emergency department. And I think really that you have to, along with the chamber, we have the opportunity as employers to identify people that have issues. And then the fourth one would be primary care. Integrating primary care and behavioral health care, we know we need to do it. It's been a federal initiative for a decade. Everybody does it in a different and unique and idiosyncratic way, but it's incredibly important because we see primary care delivering almost 70% of the services of behavioral health to folks that never come to the providers. So I think those 4 touch points are very important. And, you know, we have the technology now that we didn't 100 years ago when I got out of graduate school. Substance abuse was a moral failing. We now know it's a disease. I love the emphasis, and want to say it again, on the chronicity of what we do. You know, recovery, you're not one and done. You're not entering the MBA after 1 year in college. You know, it takes a long time and many, many failures. And some of the most compelling statistics that there's almost an 80% failure rate to all interventions in the area of substance abuse. Finally, they take. AA can work for me. It may not work for the next person. So I think we have the technology, and it's just getting to the point of identifying the right door and the right access points.
Well, you get to a point where you think about it, it's the profound change that we have. One, that it truly is a disease. And then 2, is that it's not a one and done. So it is not something that, hey, you're going to apply a Band-Aid, you're going to apply a procedure, if you will, and it's going to be over and we can move on. It takes time. All right, so now let's dig into a couple more focus questions. So Michelle, I'm going to start with you here. So building on those answers. So we clearly have a crisis, if you will. And so whenever there's a crisis like this, there's a question of resources, right? So the question is, how do we find that right balance of the resources we put at the problem at hand as people present with the addictions they have, as opposed to how much do we put in preventative, how upstream of the problem? How do we find that right balance? And if you really want to go out on that limb, what is that right balance of preventative and then reactionary care, if you will, in this particular space?
Sure. So in a word, yes, I do believe that we really need to focus on the prevention. So to take my mountain and avalanche analogy, we really need to get to the top of that mountain and figure out what is causing folks to get to this place. When we talk about prevention, we've heard a lot today about some very good theories. We've heard about anti-stigma, which is certainly a big piece of it. We have heard about other initiatives to sort of bring awareness into the workplace and have this as a sort of normalized part of our conversation. Right. I think we really need to, from a prevention and public health standpoint, consider the public health model of really flooding the country with information about this. Mm-hmm. So similar to, I use the analogy of when I grew up, if someone said, what do you think of cigarettes? 50% of kids may have said, oh, they're yucky, and 50% would have said, oh, I don't know, my parents smoke. But now if you ask children in elementary school, hey, what do you think of cigarettes? They say, oh, it's horrible, it's disgusting, and it kills you. So we have done, that has been deliberate messaging, public health announcements, and campaigns really to help bring awareness from a much earlier age. When we talk about prevention, starting the discussion in adolescence and early adulthood is just not effective. At that point, we have already missed opportunities to normalize talks about mental health, stress, depression, anxiety, and really truly understand collectively what those are. Because if we poll 100 people in this room and say, what is depression to you? Well, you're going to get 100 different answers. And they're all right. They're all variations of what's right. But the point is for us to have conversations about it where it's normalized, it's accepted, it's understood that it can affect any of us. And I think that that's bringing that mental health piece into the discussion from a much earlier point in time is just critical. Mm-hmm.
And you mentioned roll back the tape before. As you get and try to get upstream of these things, that's where you can have that biggest impact. All right, Dr. Dempsey, question here for you. So you mentioned the health plan's role in identifying members that are predisposed or are moving towards this addiction. What are the ways that you all have used, or what methods have you used to try to identify members in your plan that are predisposed to this or are really truly suffering from addiction?
So that's a great question. And the way we identify and collect data on our members is through the services that they utilize. And one prime way to understand their opioid use is through their prescription benefit. So we do monitor that. We look at how much, how often, and how frequently they are getting a new or a repeat prescription. But it can't stop there, because our members can avoid us capturing that information. And as we have put controls in place to limit the amount of opioids that can be prescribed at any given time, we have to look at other ways to monitor to make sure that they're not circumventing the system, if you will, or being pushed to use heroin, for example. So as we close the door on prescription meds, we have to monitor other areas to make sure that heroin use isn't increasing, where we might see overdoses in the emergency room, repeated admissions, withdrawal episodes, or worst case scenario, even death. So we look at all of the data that we collect on the members from the time they enter an inpatient arena. What did they go in for? How often have they been there? And how can we help coordinate that care and get a deeper window into what is happening with them? As a corollary, we work very hard to reduce the prescriptions, and our goal was to reduce those prescriptions for opioids by 30% by 2019. We reached it in 2017. So we have really narrowed that focus, but we have stepped up our surveillance on our membership through other ways, through our case management, talking to members about what they're experiencing, what medications they're using, what difficulties they're having with that, working with our behavioral health counterparts to understand comorbid conditions that may be driving that utilization that we're seeing on the medical side that really may have a behavioral or substance use root. So we have to work across all of our medical directors and nurses and case management and the members and the providers that we work with to really be able to understand the full scope of what our members are experiencing and at what point we can intervene appropriately.
Just a quick follow-up is because you all identify members for lots of different reasons. Is this harder? Is it harder when we think about substance abuse to try to identify those members, or the opioids?
No, I don't think it's harder from the standpoint of collecting the data.
Right.
We're monitoring that information. We look at substance use or opioids as a component piece of any treatment that a member might be receiving. Mm-hmm. So there isn't a stigma there with regard to collecting that information. Right. We're looking at everything that happens to the member as they use their benefits.
Fantastic. All right, Dr. Diminick, so at OrthoVirginia, it sounds like that as you've organized processes to try to adapt to the opioid crisis, can you share some of those processes that you've adapted? And the one follow-up question I'd have is, have those been harder to try to implement? Just your sense of what that sort of change journey, if you will, as you've tried to implement those, what that's been like.
Sure. So at a recent meeting, statewide meeting, where most of the members were present, we presented our recommendations from a opioid task force that we have within the organization. And to get orthopedic surgeons to not talk about the latest, greatest surgery and talk about this issue was quite a task in and of itself. But what we realized, we were taught to give a prescription for 40 by our attendings, so we don't get a phone call back. They didn't want a phone call back. So we were just writing numbers big enough that the patient would never run out, right, and the attending would never get the phone call. That's literally how we were taught 20 years ago. So now we realize that not every injury requires, or every surgery requires the same number of medications. So we're trying to be more targeting patients and their conditions with the appropriate type of medication, strength, and quantity, mm-hmm, so that they don't have that 60 jar of Percocet in the medicine cabinet. So that's one thing we're definitely working on. Just publishing the number of patients that we have with, no one hates to be on a list where they're at the top of this list, in particular where they have patients on long-term opiates. And once we published that, we went from doctors having 20 to 25 down to 3 in just a couple months period of time. So we responded very positively just to being aware that we were contributing to that problem. The next thing was leveraging technology So we have the EPIC EMR, electronic medical record, it also be called the expensive medical record. A whole separate issue for the chamber. In Lynchburg alone, a 10-year cost for between the hospital and orthopedic center of just orthopedics, let aside the other disciplines, it's going to be about $160 million. And that's in every state, meeting with regulations. That's a whole nother issue that you can take up another time. But finally, we're able to leverage that. And with the PMP, so we're seeing a patient, we can click on in real time and see what their prescriptions are. So prescriptions don't get sent out now without reviewing that. And when we order a medication, we get, if we exceed the recommended dose, we know that and we can adjust it. So that's been great technology that we've availed ourselves of. And probably the most important thing that we've done is we have a Central Virginia Opioid Task Force, which is a collaborative effort. One of my nurses who runs the program, Mandy Cock, who's done a fantastic job with us. She's here today, was recognized by the Medical Society of Virginia for spearheading the efforts in this area. So it involves all sorts of providers, surgeons, primary care, dentists, pharmacists, the police, the state police, the regional jails involved. The VA has representatives there. So we have all these stakeholders in the community that meet once a month and have worked on education efforts for providers, education efforts for patients and people in the community. And that's probably been the one thing that you can see the biggest impact across the community. And I think it's something that we can do in our communities across the Commonwealth, because that's one thing we can go back and work on, like they're doing up in the Valley, a similar sort of program that I was very impressed by. But to be able to do that and have a multifaceted approach, because this is a multifaceted problem, and just simply having orthopedic surgeons prescribe less is not going to address the problem.
Well, it's a great statement, a multifaceted problem, and it sounds like it's a multifaceted approach to that change, dealing with the logical side, the emotional side, and the environment. So that whether it's the medical record that drives that environment, expensive or not, but as well, then there's the task force that really gets the emotion of the people of multiple disciplines involved, and then it's the logic, just making people aware of the data that supports that. So super. So as we think about that and those challenges that exist, so Jim, I'm going to sort of turn to you as you think about the work that y'all have done at Bon Secours, as you've looked at implementing programs aimed at attacking the opioid crisis. Just give us a flavor of some of those programs, if you would.
Yeah, the programming that we have is largely our inpatient initial orientation, but at the point in time, we have a pretty robust outpatient program. We have 2 certified addictionologists here in the Richmond area as well. I think one of the biggest concerns for us is really using the technology that we have. You know, Dr. Diminick indicated the EPIC. We have a very robust program to see people who are what we would call frequent utilizers of our EDs. So if you come to an ED at Bon Secours and 2 days later you're in another one, our technology is going to let you know that you are shopping an ED. And it may or may not be a medically driven purchase that you seek. So I think with prescription monitoring, and I think with some level of surveillance, which is kind of an insidious word, but it highlights the fact that for many people that are involved in substance abuse, obtaining the drug and the process and the purchase is as seductive as the fundamental physiological changes by a drug. I think one of the more compelling things I ever heard with Dr. Hazel's task force. We had somebody come in and talk about, and it was somebody that could be sitting in this room with us looking wonderful in a suit and a tie or a dress, and it was somebody who just talked about all the felonies he committed to obtain his drug of choice. From stealing prescription pads to making prescription pads to developing friends who had prescription pads and had drugs. And I think, you know, it echoes the fact that it's not going to be a singular, I mean, it's a very hydraulic process to attend to somebody's issues with substances. And I think we really are on the cusp of knowing we have the technology, knowing that we have no choice but to forge forward and to not judge people for this, because it is indeed a disease. And I think that non-judgmental aspect to what we do as citizens, neighbors, friends, and family also will be echoed with reducing the stigma of seeking care.
Right.
And I know at Bon Secours, we probably have a more significant wellness and employee assistance program than we probably do in our own treatment programs for patients we serve. And I think that's why we have this panel, and that's why we have a day dedicated to this topic.
Jim, just quick reaction. Of the things that you've done so far, what's the one that you're most proud of?
That's a difficult question, because I think for me, the way I look at what we do in healthcare provision is every time somebody leaves our care, whether it's an outpatient procedure, inpatient, somebody who may even just you see the caravan downtown for 5 minutes for an aspirin, I think that defines us as providers, and that defines our reputation. So I like to look at the individual, because when you look at it as a system, or you look at this room full of people, it becomes very daunting. So I think you have to go down to the individual level. And I think you've heard commentary this morning about putting peer support recovery people in our EDs. You know, you've got to get people for when they're ready to change. And, you know, it's kind of a clinical word of, you know, readiness for change. But there are people that can be functionally addicted and involved in substance use that we don't know. And I think you really have to hit people when they're ready, and forgive their trespass when they're not ready.
Well said. All right, so Sharon, let's turn back to the pharmaceutical industry. And what are the policies that, as an industry, y'all really support to try to specifically fight this opioid crisis?
So Scott, we've worked for the past couple years with a number of groups, the National Governors Association, the Lieutenant Governors, a lot of legislators, and we've seen state laws go from well-intended laws that have gone too far. We cannot forget in this discussion the 25 million Americans and patients that have pain on a daily basis. So unfortunately, some of the states have gone too far in regulation or legislative action in attempt to reduce the opioid crisis. So that's a concern, that those that need legitimate access to medicines and pain medicines have the access they need, because we all know family members or ourselves who have lived with debilitating pain, it just can be intolerable. However, we are working actively, namely with the Governors Association and some other stakeholders, to really do a couple things. One is we had referenced, Jim had referenced the PDMP, the Prescription Drug Monitoring Program. Virginia, the Commonwealth here, has done an incredible job with PDMPs and mandatory checks of the PDMPs, making sure that we're preventing doctor shopping. I worked in Michelle's hospital up until about a year ago in the emergency room in Fairfax on the weekends as an ER nurse, and I'm telling you that, just as Jim said, people that look just like us coming in, doctor shopping. A woman a little older than me has smashed her hand with a hammer and said that she had closed her hand in the car door, helping her mom or her elderly mom into the car. I checked the PDMP because we have delegate authority here in Virginia. As a nurse, I can check for my doctor. And sure enough, she had been down to Reston Hospital, just 4 minutes walk from where we were at the urgent care there, and just had doctor shots. So that said, I think PDMPs and enhancing and strengthening it, making sure it's interoperable, that all states connect, that Virginia has access to physicians, like our physician here has the access to the neighboring states, even Kentucky, Ohio, Florida, since we know not everyone stays in the same state. Some spend part of the year in other states. Number two, looking at more rigorous education with our prescribers, the nurse practitioners, the PA, the physicians. Number three, would like to work on supporting the CDC script limits. PhRMA has come out in support of the CDC script limits, a huge step for us because we stay out of the prescribers' business. Medical schools and nursing schools are the ones that train providers, but this is just reasonable. Why would you need more than 7-day scripts? However, we support provider exceptions for those that need it. And then finally, looking at enforcement mechanisms, looking at quotas. The DEA regulates how much supply our manufacturers can make. Maybe someone needs to look more closely at some of the quotas and the supplies. If there's a strange surge in request for supply in an area, that needs to be looked at. and looking at enforcing things. Is it a pain clinic or is it a pill mill? You know, how do we differentiate? So those are 4 main things. We can go on a little further, but I want to just highlight that in addition to our product solutions.
Well played. All right, fantastic. All right, Michelle, so the spirit of the avalanche has sort of stuck with me. So now let's take that one step further. So we've talked about this, but give us a little bit of your thoughts on, you know, is mental health a contributor to the opioid crisis? And if so, how significant of a contributor to that crisis do you think it is?
Yeah, and I think I've sort of touched on this in earlier points, but in a word, yes. Mental health is a critical component of this, and what we mean by mental health is all sorts of things. One of the questions you asked Jim, I'd like to answer for Inova is we've implemented integrated behavioral health in primary care settings in 18 of our clinics in 2017. So we're very proud of that. And as a result, what we're able to do is fill the void between substance abuse outpatient treatment, emergency rooms and inpatient detox, and then sort of what's going on in the middle there. And what we're able to do is treat folks, anyone who has access to their primary care doctor, who goes in with stress or anxiety or life changes. You know, I just got a divorce. My child's giving me a hard time. They're poor performing in school. All of these life stressors that, if they go unaddressed, become bigger and bigger. And really, we have the ability now in our primary care centers to say, hey, you're going through something. I get that. There are lots of ways we can address this. One is medication for depression or for a lot of different things, but another is to talk to somebody. So let me walk you down the hall, and you're going to talk to this licensed clinical social worker who's a therapist, and you're going to kind of sort out the problem with him or her, and then let's come up with a plan together. So that's the approach. And what that does is it has the ability of really saying to a patient who doesn't know, this is normal, this is your mental health, this is your well-being, and we're here to kind of come up with a plan to help you fix this together.
Well said. So Jim, sort of continuing on that path in the behavioral health wing of the panel, you know, as we begin to think about reform. So we heard some of that conversation earlier this morning. In your opinion, and Michelle, feel free to chime in on this too, what are the mental health reforms that really are needed to help address the crisis? And Jim, I'll start with you, but Michelle, please.
Yeah, I think you've heard a couple of them already, and one of them is we have to decriminalize substance abuse. Mm-hmm. That doesn't mean that you can't commit a crime while you're abusing substances, but the mere act, I think that's a major point. I think accountability courts, we heard drug courts, accountability courts work. You know, if I'm facing a felony and all I have to do is stay in treatment and be compliant for a year, my felony goes away. That's motivation 101. You know, that's hitting a person, they're finally at a place where there's a fulcrum to make them make some significant changes. So, you know, to Michelle's point, you know, this is more than just handing somebody a brochure. This is more than a TV in the emergency room saying, call this number if you have an issue. It's more than a billboard. And I think you really have to approach it one intervention at a time. And we have to make treatment more convenient than it has been in the past. Again, not that long ago, substance abuse treatment was defined by the payer plan. You know, I was a CSB director and I had a 5-day detox followed by a 28-day inpatient program for substance abuse because that was the payer-driven model at the time. And we've come so much more, we're more adept. I think we're more sensitive to the needs of the individual and that we have to approach the people when they approach us. Right. And not wait for them to do that. And that's why I think the integration of primary care is huge.
Gotcha. Well said. All right, Dr. Dempsey. Talking again, sort of in the health plan space, or Anthem in totality, is what are the things that y'all are doing to sort of increase the capacity of the healthcare system to not only treat folks, but as well engage them in that treatment around whether it's whatever type of substance, if you will.
Great. And you've heard this morning how important it is to partner medication, for example, with the counseling, the behavioral health services, and link them up. Part of what we do, once we identify members who are at risk or who need services, is to find ways to link them to those services. And that means that we have to build that capacity through our own network. A lot of that work, fortunately, had begun with DMAS and the Medicaid plans through the arts effort that has been ongoing for several months. And that has rapidly expanded the amount of treatment that is readily available. And we're building on that on the commercial side. And the nice thing, you heard, if you build it, they will come. Now there are other treatment providers who are interested in expanding those services within Virginia. And that creates opportunity for us to get members to services when they need them, when they're ready for those services to occur. Some of the other things that we've been working at are new and novel ways to get that service. You can't bring hundreds of behavioral health providers into the Commonwealth in short order. So what other ways can we expand access to care that get members to where they need to be and into care when they're ready? Looking at telehealth, there are services on the behavioral health side that support the counseling and the substance abuse intervention along with medication, for example. There is a program out of West Virginia University Medical School working with PCPs to expand their knowledge base and their understanding of the link between hepatitis C increases and the current opioid or substance use crisis that is going on. And that particularly helps in the rural areas that are hardest to build capacity, build systems of care, if you will, and have high needs in those areas as well. And we continue to work with our existing providers to help us, help our members navigate where they need to be and get the services that they do.
So capacity and access, that's fantastic.
Yes.
So Dr. Diminick, so turning back to the physicians, what are some of the traditional training methods that likely need to be reconsidered in light of the opioid crisis? You mentioned a little bit around just sort of some habits, some learned habits, but I didn't know if you could expand a little bit more on that.
So if you look back at how physicians were educated 20, 30 years ago, there was a concept that was promoted back then that if a patient had true pain and you gave them narcotics, you could not make them an addict. And Dr. Dempsey probably learned the same thing. It was not based on a study. It was based on a letter to the editor in the New England Journal of Medicine. People picked up with it, and it just spread everywhere. So we were brought up to believe that we were doing the right thing prescribing these patients and these prescriptions. And clearly it's not the right thing, but that ingrained in us that this was okay. It's well documented in a book called Dreamland by Sam Quinones. You should write that down and get this book. It's a fascinating book. But in that book, they talk about that very thing, coupled with the fact that JCO came out years ago with pain as the fifth vital sign, and we had to treat pain, and we were nailed if we didn't treat it appropriately. And then finally, the report cards that are so ubiquitous now, Press-Ganey and things like that, that if you didn't treat patients' pain, you were going to get a low score. So this was a perfect storm as all three of these issues came together. Poor education on our part, and then the reporting methods in JCO. So it created this situation where numbers of prescriptions went up threefold, like I said, where I trained in New York in just a couple years period of time. So educating patients and the providers is key. I think you've seen that, the numbers that people have alluded to, the 30% reduction already. So, doctors want to do the right thing.
Right.
And once we have that information and then the resources to make it happen, it can happen. So,
Gotcha.
so we have responded. I'm glad to see that, but there's certainly more that can be done. One thing that we haven't alluded to is just how to dispose of drugs, and whether you have drop boxes that can be set up, which are few and far between, or disposal kits that can be provided, where patients, when they have that prescription, they've only used 5 out of that 40 in the bottle. How do they dispose of those? And there's ways that may be something on a community-wide basis that we can look at disposal methods.
Gotcha. So Sharon, right quick, I just want to ask you one last question before we get to the lightning round. Yeah, we've got a lightning round. So we talked a lot about prescription limits. How do we make sure that we don't go too far? You alluded to this just a little bit. How do we make sure we don't go too far with those limits and impact those patients that need those medications?
Well, quite simply, I think it's involving the prescribers. I don't want a bureaucrat making a decision for how much medicine I should have. I want a healthcare provider that's been well-trained. I want a nurse practitioner, physician assistant, a doctor. So making sure that those people that interface with a patient on a daily basis and understand the treatment guidelines and have the expertise in managing pain are involved in the legislative decisions, the regulatory making process is paramount.
Right.
So having that as a voice, and we can't leave out the patient. A patient needs to be present as well.
Well said, well said. All right, so Jim, we're going to start with you in the lightning round, and so we're just going to come down the row. Gang, as we go through, what do y'all think, in just a couple of words, what do you think it will take to reverse the trend that we're experiencing now with the opioid crisis? So what do y'all think it will take, just in a couple of succinct words, if you will? So Jim, we'll start with you and just work our way down.
Yeah, I think it's education. I think it's awareness. I think it's an acknowledgement that we have a problem. And, to suggest that it's not a problem because the numbers of people that go through my ED or come through my treatment programs are on the decline, or the fact is that substance use, both legal and illegal, coupled with mental illness, the concomitant diagnosis is about anywhere from 60 to 70%. If you have a psychiatric illness, you're likely self-medicating in another vein. So I think it's awareness, and through that, the second one would be forgiveness, and that is, we're not going to just put a scarlet letter on somebody. We're going to handle their issue one person at a time.
Awareness and forgiveness. I like those two. Michelle?
Yeah, I think moving forward, we've done a great job reacting. I would love to see our collective focus on being more proactive in terms of identifying this much earlier on, giving doctors the tools to identify it, which I don't know that is happening in medical schools, and I think that if they're given those tools early on in their education, they will embrace them. For legislators, we do a great job with top-down. We're doing a great job with the prescription monitoring program, with jail diversion and things like that, where we really need to meet them with bottom-up solutions that address just that education, tailored, individualized treatment, and looking at truly what path has led this person to these places. And the last thing I'll say is that it's not the doctor's problem. It is not the mental health person's problem. It is your problem. It is my problem. It is all of our problem. And if we are faced with this, my challenge to all of you is when someone in your life is struggling with something, is having a mental health diagnosis, maybe drinking a little too much, that you stop and consider, how can you affect one person? And believe that even if you don't think that you can do that, just talking to them and asking about them, and as employers giving them the opportunity to get support and help when they need it, is a critical first step. So just kind of consider that.
That's a
Diminick.
Fantastic point. What I would also add, the task force idea, however you can do it in your community, this gets to the education, it gets to getting everyone on board and to solve this collectively. So I think hopefully we can talk at lunchtime. If you have any interest in this, I'd be happy to talk. The other is, we're swimming in data. The hospital data, insurance data, physician data. There's unbelievable amounts of data out there. And medicine is just terrible at harnessing data. We're so far behind other industries with artificial intelligence and creating algorithms that can take this and help us to boil it down to identify those patients who are most in need.
Great. And I could easily echo the comments about prevention. I was stunned when I was looking at the data, the number of 12 to 17-year-olds that have tried heroin. That is truly frightening for me as a pediatrician, but also thinking about, what that means for them for the rest of their life. So I think the prevention and the early identification and finding the reasons why, and the screening and the training of providers to do that screening, and other individuals who interact with our adolescents and young adults is critically important. And then secondly, I think we need to think outside the box. It isn't enough to give somebody access to treatment if they're going back to an unsafe environment. So everything else that goes along with using substances, other individuals in a home may be using those substances and not on the same treatment path. And so, success for that individual may be a safe place to live, as well as access to medications and counseling.
Fantastic. Sharon, bring us home.
Great comments here. In addition to swimming in data, I think there's a lot of finger pointing. And I think if we can stop finger pointing and roll up our sleeves, work together, collaboratively, interdisciplinary, across all sectors, law enforcement, religious community, education, parents, the healthcare industry, we're going to get far. We want to make sure we never made our medications that with an intent that somebody abuses them and, God forbid, dies. Where they're to save lives and improve lives. So with that said, we want patients using them exactly as prescribed, not sharing them, storing them safely, and disposing of the unused medicines in a safe manner like household trash.
Well, so if we think about it this way, if we take what this panel talked about and we say we get awareness, we get forgiveness, we have proactiveness as we move forward through this. We help to harness data as opposed to just swim in it, which I agree. And we train and we think a bit outside the box. And finally, we stop finger pointing. Because as Michelle, I think as you shared, it's everyone's problem in this room. And how we move forward as a society in this Commonwealth and beyond its borders is going to be together. So great time. Panel, thank you so much for a great conversation. And